is that we could help clear that debt for them and we could put them into balance, because we are part of the solution, because we can improve the physical healthcare outcomes of the physically ill, because we have a psychological understanding. A fifth of patients with breast cancer will develop depression in the first year after diagnosis. And what do we get? Well, you've got cancer, you would be depressed, wouldn't you? Not good enough. We can't stand there without blame. At the moment, Jeremy Hunt has produced some indicators today about reporting of safety incidents. He reckons there are 100,000 avoidable deaths in England every year. We have given him evidence that over a third of those are deaths linked to people with mental illness, where we've not done well on their physical health care, hence this joint statement today. He somehow won't believe me, and it's not about suicide, it's about the poor physical health care we give to our patients. And we know there's a growing awareness of that across the world. 1 in 4 adults and 1 in 10 children are experiencing a diagnosable mental health problem at any one point in time. It was only recently that a wonderful body, the WHO, actually saw mental health as a non-communicable disease. Well, what else has it ever been? And thanks to people like Norman Sartorius and the late and much lamented Hamid Ghosh, they now have this as a non-communicable disease. So we need to be grateful for that. So we sit with the long-term conditions. Mental health and substance misuse disorder account for the second highest proportion years lost to disability. In the UK, 21.5% of the total. We do have this burden on society, but our patients are not a burden. Our patients are human beings who can be helped and supported if we listen to them. So I met with Margaret Chan, who's the medical director of the WHO, by chance when I was somewhere else. And I've just had a letter from her saying that she will pledge for parity for mental health, but also for physical health, and she will try and ram that into the United Nations. And I'd certainly like other presidents from other countries to help Simon and myself in our new role to push on that. I think we must remember that we belong to the family of medicine. And I believe that medicine is the art of science, ways of seeing and ways of being. And I've been privileged to be the Vice Chair of the Academy of Royal Medical Colleges, where I've led for quality in education. I've had great understanding from the rest of medicine, and I hope that we've been supportive to them. So we really have to move forward. I learned this late in my career when I was privileged to work with a speech and language therapist, where I was having to assess people I was not skilled to assess. They were profoundly deaf and had mental illness. And I deal with young offenders and have committed grave crimes. And I said, I don't know how I'm going to do this. And she said, I'll help you. And here, and I'm not going to read them out, is really what I think we do each day. In every interaction we have with our neighbour, this is what it's about. And it is about the art of communication. And yet these days, if we turn up with A&E, which I regularly do with my grandchildren who are always falling over, I still don't, I feel when I get there that it's a head injury. What's the first thing they do? They don't really take the history. It's easier to shove them into a scanner. We've lost the art of taking histories and listening to stories. So I think we need to hold this in mind in all our interactions. It is about being human. And at the end of the day, whilst we still need inpatient beds, and we're short in England at the moment, and we're short of intensive community care because we're short of money, I feel I have to keep getting the message over. People live in society, they don't live in mental health services. And I hope the users and carers in the audience will feel that this graffiti, which ironically sits under the building where the big DH building is at the Elephant and Castle, please dispose of hopes and dreams responsibly. Well, why should our patients dispose of their hopes and dreams? They're as entitled to them as everybody else, but we don't always treat them in that way. What sort of psychiatrists should we be? I never know what's happening here with these, it's just a surprise to me. Okay, well, Helen Lester, who is a senior general practitioner, told us at a conference 3 years ago when I just came into this role, She'd like us to be able, informed, accessible and affordable. We both agreed that we were probably never as psychiatrists managed to be cheerful, so she was willing to waive that one. Users and carers want us to be empathic, listening to their stories and working with them in real partnership, not tokenism. And that actually makes us uncomfortable because it's not how we've been reared and trained. I just want all of you at the next break to rush to the college stand where I want you all to buy a book, Intelligent Kindness, authored by a married couple, always a risky thing to do, one a psychotherapist and one who's had extensive experience in management in the NHS. This book tells you anything you need to know about how you can get what you want by actually helping people to get what they want. I'm a child psychiatrist and we ask children silly questions which include what are your 3 magic wishes, which in my case is for the young person to tell me to F off. Second wish is to definitely F off. And the third is, if you don't F off, I'll set my Rottweiler on you. But my magic wish for you is to be bold, brave, but beyond everything else, ethical. So I'll keep going. Well, I arrived at this strange party. It was a last-minute decision to stand as president, so it left me in a position of having nothing to lose and probably saying, well, what can happen? And I arrived in a stormy start. So in England, we had a complete meltdown and breakdown of the NHS, which has been partly dismantled, and I won't go on about it, else I might get PTSD. But in the beginning of this, what we did get, and that was down to the voluntary sector and to peers in the House of Lords, and it was actually a physician who stood up and got this in, that we got parity between mental and physical health. But it was the whole family of what we do in mental health. Not just treatment for those seriously ill, not just prevention, definitely diagnosis, but the whole kit and caboodle together. So we've had to live with and use that. I pitched the idea of parity from the APA when we went over to see them, and then it was very much the talk. Obama wasn't yet president, it was very much about affordable mental health care. I understand parity's come to have a different meaning over there now. And in 2011, it was an argument, why can't we have parity? 2012, 2014, everybody signed up to it. So the challenge for the next 3 years is, now we've got it in word, how do we get it in deed, and what will it look like in practice? Because the worst thing will be to get it in legislation and nothing happens, and we all know that's fairly common. So just in case you don't know, when you go to work in the morning, this is really what you're trying to do. Give equal access to the most effective and safest care and treatment for your patient. Make equal effort and make everybody else make equal effort across medicine and social care to improve the quality of care. Put in time and effort and resource. It actually, don't tell anybody, keep this a secret. It doesn't have to be on a basis commensurate with need, but certainly the gap between 11% of funding and 22% of need is not good enough. I'm hoping my next role to do, if I've not been sacked already because of what I said to Jeremy Hunt, that we'll get equal status within healthcare education and practice. So if anybody in this audience across the world can tell me that the training for medical students in medical schools has training commensurate with the disease burden that mental health causes, then please let me know, because you've cracked it and I need your help. We've had it pointed out to us, and it's a very sad and bitter truth, that we don't have equally high aspiration for our service users. Well, he's a schizophrenic, so he wouldn't work, would he? We'd not say that if he had cancer or diabetes. And although we don't like it and we've avoided it, measurement of health outcomes is necessary. Unless we can measure things, I'll come on to this later, perhaps we measure the wrong things, we're not going to go to the outcomes party because you have to have some figures to take with you. Parity in action, we've already discussed what we're doing for the GPs, and we're joining with other colleges, and we've formed 4 working groups. One is recognising the deteriorating patient, looking at very practical things, and forming these working groups and actually translating that into what training would look like. And I'm very grateful to the Dean here at the college and the Dean at the GPs and the other colleges that we will make this happen. So, how do we deliver what we want? Communities that care, parity, compassion and intelligent kindness. Realising parity. In England we've had a Mental Capacity Act, which if somebody read it closely would actually tell you how to communicate with human beings. In this case, human beings who may or may not have intellectual disability, but certainly are not going to understand informed consent unless it's carefully explained and checked. We've got our slogans, we know what we need to do. I'm going to talk about sustainability in mental health care, which I think many still don't get. And I still sit with great worries about mental health and justice and inequalities. We have a real task on our hands to see how research can be enhanced and funded, and how research can always be made to be used for patient benefit, whether it's a Nobel Prize winner or somebody who finds a better way of delivering services. I don't talk much about leadership. I've got a bit of an allergy to the word. But if I have to, it's getting real about what is the best use of our skills, and that is undoubtedly in leading teams. Government's getting real about facilitating how we can work across health, social care, education and justice in a better way to actually help our ministers of health across the world, of mental health, to have more influence across government, to get money off justice, to get money off to get money off other parts of the system. Working through intelligent kindness with a values-based approach, and the chair of our child faculty, Peter Hindley, is putting together a children's commission. And the only reason I want to talk about that because of all the stuff that Peter's been doing, but the bit that I've enjoyed most about this, and you probably won't believe me, is that the person who's given us the money to do it is a surgeon. So really, they do understand. My apologies to everybody in this room who's been on council, where you've had to listen to hours and hours of English-centric twaddle, because we can't unobsess ourselves from the framework in which we live. And too often, we know that across life, form dictates function, and that results in navel-gazing, and as shrinks we do enough of that, frustration and risk-aversiveness. We've got to stop looking inwards, we have to look outwards, even though it's taking a risk. Better take a risk than do nothing at all. I suppose this is my public health PowerPoint. How do we actually deal with inequalities? Every government across the world that ever gets into power says, yes, we will close the inequalities gap, and I just groan and groan when they say that. Because do we really want equal access to health and social care? The risk is that if we go that route, the inequalities gap will widen and not reduce, because those who know how to access what's on offer will access it, and those who don't and need help won't. So why can't we be honest? Well, because it's not politically popular. So should healthcare services cater disproportionately for those with most severe problems? Absolutely, yes. That's where our skill set are. There are lots of people who can do prevention and well-being, and we need to sit in the interface of primary care. Healthcare is holistic. Poor mental health is a cause of physical illness independent of healthy lifestyles and treatment for mental illness. Therefore, should we not get real, and the recognition and therefore aspiration to be that the gap cannot be entirely closed, shock horror, until we can enable everyone to be mentally healthy. And in June I take on the role of the Inequalities Forum Chair at the Academy, so this is my opportunity to have a go at this. I'm going to go to a bit of doom and gloom, and I'm doing okay for time. For those of you who don't live in England, there's been a series of things that have meant that doctors have lost the responsibility to self-regulate. We've not been good. A few people haven't been good. And then it went into a whole system drive where a trust in mid-staffs were pushed and pushed and squeezed because money was taken to the flashy new acute trust down the road that had academic status, and all the money got squeezed to them. And then there came an inevitability that this trust was told, you must save, you must cut, you must cut, you must cut. If you bleed sufficiently, you hemorrhage and your practice gets bad. And it culminated in one of the very key poignant findings was that an elder of the world who should have been respected was left lying in his bed, dehydrating, where eventually, being resourceful, he started to drink water from the flower vase on the side of his bed. And we all go tut-tut, we'd never do that. But we're all doing things like that day in, day out. and it's just staying ethical and catching ourselves. We had our own Winterbourne View. Winterbourne View was where the Panorama programme went in, did secret videoing of staff in a residential home for those with intellectual disability who carried out sadistic and violent acts against those they were charged to care. But Winterbourne View arose as a consequence of placing vulnerable people, most of whom didn't need to be in institutional care, with challenging behaviour, which they definitely had, under the care of ordinary people. And I think most of us should aspire to be ordinary because that's a good aspiration. But they were ordinary people who were placed in a closed environment. So the primary failing at Winterbourne View was not a failure to recognise that abuse was going on. That was the secondary failing. It was a failure to recognise that such behaviour was highly likely to arise in that setting unless active steps were taken to prevent it. Education, supervision, monitoring, time for reflective thinking. There were lots of studies in the 70s where people had experimental designs where if you put ordinary decent human beings in environments, they will eventually behave badly if those environments are not designed to help them behave well. So we were the last college to come up with a response. They're there, I won't bore you with them, except to say I think the important thing is that we're starting a new programme with Alan Wilkinson on Start Well for revalidation. Our medical psychotherapists who are fantastic are running balance groups for medical students, so I'd like them to start running them for us. Where medical students are getting balance groups, it's shown that they're more empathic doctors, they're performing better, and their tutors feel better, so it's a win-win-win. What were the enemies that this situation could arise? What the Francis report told us was that we were not listening to and acting on the stories of patients or carers. We'd got into a false dichotomy of clinical leadership versus management. And frankly, doctors had become in the situation of learned helplessness. Whistleblowers weren't believed, and there's lots of work we're doing in the college there, because still the most frequent email I get from members is, it's all very well you saying I should speak out, but it's not safe to do so. And I guess that might be the same the world over. So what was missing in the Francis analysis, and he was a very bright and is a very bright lawyer, and we've had discussions and ongoing discussions about this, was the psychological perspective. So what are the friends and opportunities for psychiatrists? Future Shaper training, which for those not living in England, is going to be about moving from specialists to generalists. So we're hoping to have shared training with GPs, with community paediatricians, with community obs and gynae specialists, with public health specialists. We have mental health champions across the UK in local councils. They may not be the lead for mental health, but they stand up in the town hall when the transport lead is talking about something. They're saying, do you know that that won't work? Because do you know people who are victims of violence may well become mental health patients and they can't cope with that sort of transport. We need more support from medical colleagues, and we've got that. All three political leaders have made speeches, and we can show you those on the website with some rather strange pictures, including me planting a tree with David Cameron, which was slightly surreal, but I'll come to that later. Why are we always trailing behind? And we're usually referred to as the Cinderella service, and I get you to bear in mind, Cinderella didn't do too badly in the end, did she? She got her Prince Charming, and they lived happily ever after. And they reigned over a kingdom that had intelligent kindness. But we're always catching up on investment. I'll try not to get too worked up, but we had money removed from this in England recently. We're still always the last in the bread queue. We account for over a third of avoidable deaths, and we've had a difficult thing in England called new ways of working, which is interpreted by more excuse for cutting. I was in two minds whether to show this one or not, but I don't think I can get the point over any other way. Just come back from Berlin, where we've been celebrating 20 years of the European Education Body for Child Psychiatry. And as you do, I went to the Holocaust Museum. There's a special exhibition there that has been funded by the Dutch Psychiatric the German Psychiatric Association. In the 1930s, it was common practice across Europe that if you were different, and Mike Schuster, the past president, said it's dangerous to be different, whether you were physically handicapped, intellectually handicapped, psychotic, or just spoke out, the chances were you might be sterilised. Obviously in Germany, under the Third Reich, and with their strange way of thinking, it moved on to that. An otherwise good and decent psychiatrist who were running open asylums in Germany became the masters at the gas chambers because they applied their science to it, and they managed to wipe out the whole population of the mentally ill and the intellectually retarded during the course of the war. To the extent, I met a lady there, and she told me, and she's now quite elderly, that as we all rose from the ashes of the Second World War, those of us in England started to go to Spain for our holidays, those in Germany went to Italy. And she sat on a beach one day, and this group of people came past, and she was just completely taken aback. She'd never seen anybody with a mental handicap or with mental illness so successful with psychiatrists in delivering death. So that may be too hard for you, so here's a softer version. Please don't trample us, we're trying to grow. I think there is a tension and danger lying about in the future. There is a risk that for those who want to split us, they've got a very easy way of doing it. So we have countless discussions about well-being, mental health issues. Well, I've never gone to the doctor or anybody in my family and saying, I've got a breast issue. I go and say, I think I've got a lump. So we've got to get the language right. But well-being is a respectable thing, resilience is respectable, recovery is respectable, and illness is respectable. It's not either or, it's all of these. And we, perhaps unlike other branches of medicine, have to do the whole kit and caboodle at some level. So just want to remind you in England that the funding comes from two separate pots, so it's not us fighting each other. Is it more money for mental illness beds, or is it money for prevention? There are two pots to go at, so we're really lucky, so we just need to do it. So I've just got some money off our local health and wellbeing board, and it was very easy. I just took a set of young users with me, and they did the talking for me, and they said, how much do you want, and when can you get it done by? So it's just a case of being bold. I want to move on to something again which is easy to diss, which is psychosocial resilience. And this is the work that our lead in the college, Richard Williams, has been done. We all know about longitudinal studies, but I want to invite you to look at horizontal epidemiology, because it recognises the quality of people's lives in the circumstances in which they live. That is our patient's existence. It combines with psychosocial care, resilience, and what we're all entitled to, a social identity. Psychosocial resilience is a science which was around probably about 70 years ago, then went into abeyance and is coming into its own. But the concepts of recovery, horizontal epidemiology and psychosocial resilience turn on trying to alter the circumstances in which human beings exist, the way in which we relate, live and work, in order to provide human beings, and particularly those with mental illness, with the opportunity to achieve satisfying social identities and derive support from membership of networks and groups. This is the work of a married couple, the Haslams in Australia, who are over here at the moment and originally came from England. And they look at the importance of social groups, and if we look across the world today, I think there are some sobering thoughts about what social groups do. But actually looking at social groups gives us the potential to ameliorate mental disorders such as depression, because in society we live in, we've evolved to function in social groups. We don't live on a desert island. Social identification is a cognitive mechanism which makes group behaviour possible. And they discuss virtuous circles of social identity. I work with young people who have vicious circles of social identity. So I work with children in gangs. And what they say to me, sadly, because so much as the rest of society failed them, it's safer to be in a gang. It's 50% safe to live in a gang. It's 100% safe not to live in a gang. We've got it wrong. Their principles are very similar to these, but they're just not pro-social. So we need a basis for support and coping, whether it's children or elders with dementia. It gives control, purpose and meaning to people's lives. It leads to health and well-being. And that starts this kick circle of sense of community. So what we're going to be doing over the next few months is to look at social identity, helping practitioners to understand why groups matter, for better or worse, actually looking at what skills individuals with mental illness need to maintain to retain connections with the community during those periods when they're either having their mental illness in their backyard or in hospital. And we need to set in social scaffolding, so that's work we're about to do. Sustainability. Please, again, in the break, go and meet with our sustainability fellow. I think some of the members of the college thought I'd lost the plot when we used legacy funding to fund a sustainability fellow for 2 years. And thanks to Phil Davison for everything he did. Future-proofing both psychiatry and communities that care requires us to maintain a broader focus, as inevitably finances continue to be limited. At least in this country, energy prices rise, the population increases, demographics change, and society itself changes. And just to get it home once and for all, but go and see Daniel because he understands it much better than us. The core of sustainability is disease prevention. Half of lifetime mental disorders have their onset before the age of 14. This is the ultimate area for prevention. It's about patient empowerment and self-care. It's about eradicating waste. And it's about low-carbon technologies. And we are high users because we have so many community services. Going to this next bit, I thought twice about it because I'm not seen as an academic. I am a social psychiatry academic. I don't think that makes me less of an academic, but it's not always seen that way. So I'm going to have a look at science, dangerous thing to do. So I think the science into practice is about psychology, epidemiology, genomics, epigenetics, drug discovery. Well, we're not going to do much there unless it's dementia. Epigenetic mechanisms, regulations, different histories, and developing novel agents with fewer side effects. I don't think we're going to be able to develop novel agents, but we may be able to repurpose drugs, and there may be new drugs for dementia. Science and practice. When you're president, you go and sit next to people at dinners, and I'd inadvertently not noticed who the person on my left-hand side was, and I suddenly thought, gosh, that little badge he's got means he's a Nobel Prize winner. And I immediately thought, God, I'm not going to be bright enough to have a conversation with him. And he said, what do you think about neuroscience? And I said, well, I think it's a wonderful thing, but I think you can oversell something and maybe it isn't going to meet its potential, but I do think it will meet its potential around mental health. And he said, I agree. I thought, thank God for that. And what he wants to do is to work with mental health professionals and those working in the field of neuroscience. And he wants to actually understand, because it's not the brain, it's the brain which is the mechanism to the mind. And he's apparently not got enough money. He's only got £750 million. And he's going to study the brains of ants. I don't happen to like ants very much. But it's interesting because looking at the brains of ants, of course, the really interesting thing about the brains of ants is when they get together, and their real effectiveness is in the space between their brains and the things that they do, so they can blissfully live mountains. So personalised medicine, I think, is the way forward, and this is going to be the new training that our young doctors and us oldies are going to have to catch up on. So what about future science and technology? The future electronic medical record, bringing trust into data sharing. Well, we've not done that very well in England. Being a 70-year-old, and I say the bad news to them and their parents is you've got early onset psychosis, but I do know your genomic profile. So actually the good news is you're likely to have low side effects from the drugs, or you're likely to have high side effects, so shall we try CBT first? Technology, a better informed public, we've got that already. Computerised self-treatments with benefits and risks. Intelligent systems, because our prescribing still isn't always safe. I'm going to get even more risky now and talk about quality improvement in innovation measures and outcomes. We recently hosted an international mental health conference at the college, and we're going to do some work across Denmark, England, Scotland and America. And of course, what makes mental health reform so difficult is system inertia. System inertia, complex, non-adaptive systems, and an averseness to risk-taking. Well, the frog seems up to it, so why can't we be? We need simple rules for the healthcare of the delivery system in the 21st century. And there is no such thing as an implementation gap. It's policies and strategies that are poorly designed and for us out on the ground, being able to implement. Innovation, we can't afford to start with a blank piece of paper. We need to recognise the reality of any health system, the complexity of what we have to call change management, which sounds sort of some very genteel form of Scottish country dancing. The urgency of making things happen in a context of austerity, and with two fantastic projects in Manchester that I'd love to talk to you about, but ask me at another time. Oh, I don't know why it's doing that. So compared with the rest of medicine, I think we've had some problems. We innovated before the rest of medicine. We emptied the asylums, we went out into community care, we had multiple functional models of community care, we didn't evaluate them robustly enough, and we were totally naive. We believed them. They said, you go and do community care, chaps and chappesses, and we'll give you the money. But the money got put into acute medical care. And when we got driven, we're not protected by finance. We still need better user and care engagement. Denise Coyer, who's a senior psychiatrist in Scotland, is now leading for the whole of quality improvement in Scotland across medicine and social care. And she showed us a wonderful style with her wringing her hair and pulling her hair out, because they had to do something about quality improvement, and she said, please do something, anything, PDSA. We've been late to the tariff party in mental health, except in the States. And there's measurements and measurements, and you have to be careful that when you collect information, you're measuring things and you're using that information safely. And we've had examples of where it's been misused. So there they are in all their glory. Our politicians, and the other countries have got their own politicians. So Paul Burstow and Norman Lamb have been Secretaries of State for Mental Health and Social Care, have been fantastic. Jeremy Hunt has been really good because he's got dementia and his priorities are our priorities. Can you just tweet that now, please? I want my next job not to go before it starts. Independent, and I actually mean it. I mean, you have to go to where they are. You can't expect them to do what you want. Independent professions are the most important intermediate organisations between individuals and the state. Durkheim had it right, but we slightly lost the right to do that by the way we behaved in the past. Okay, well there they are. I don't know what your government structure is, but Big Bird. I've only got 3 birds there. There are 4 birds in England now. NHS England, I'll get them wrong now. Health Education England, which I couldn't include because I'm going to work for them, so it didn't seem a good idea to be rude about them. Monitor and the Care Quality Commission. And you'll all have your own birds, but really, they're very loving, really. Just reframe. Influencing politicians. This again is in the underpass of the great Department of Health building in Elephant Castle. This was never correct because there were 4 politicians, but of course it's just turned out right in the last few weeks. So there they are: David Cameron, Nick Clegg, Ed Miliband, and for those who are not in England, ask a friend who is from England, Mr Farage, who now has a health advisor. So I'm going to see the health advisor about the inequities in service provision, or lack of it, for children with mental health problems. Nearly done. I actually think it's fine. We had him to dinner, we didn't eat him. Our dean thought he was charming, and I think he was charming, and he understood that it's a difficult role to be a politician, and you have to go home to a caring and loving family. And he set his priorities: the frail elderly, we have no problem there, except James Warner, as chair of the old age faculty, is trying to explain to them that frail elderly means more than dementia. And the biggest problem for the person dementing and their carer is not just the dementia, it's the functional psychosis that often sits alongside it. He's going to do long-term conditions. Well, joy, that's us. He's going to get round to the lifeboats and women and children. Great. And he's going to do prevention and resilience. So as you can see, we are as one. So, I'm just going to get this out. I'll take that one out. Things come of their moment, and you have to go with the moment. And at the moment, the buzzword is liaison. And the chair of the liaison faculty is doing great things. But every bit of psychiatry has to bring the liaison out in itself. Primary care liaisons sat with the general practitioners, working with them, liaison at whatever emergency services you've got, and liaison to secondary care so you can help physicians improve their outcomes. So why aren't we up in the UK in community and mental health trusts? We should be running diabetes and rheumatology services. Why should patients have to troop up to acute sector hospitals when this is a chronic long-term condition? And where mental health trusts and community trusts have taken over, the outcomes have been better. The GHQ of the patients have improved, they've been more compliant with the medication, and the diabetologist GHQ have improved. So it's a win-win-win. So please, oh my gosh, show me that. That was a bit drug enhancing. So taking a 360 degree of life. When we go into work in the day, this is the thing we can't find time to do. The views aren't bad, are they really? So why not enjoy them? Changing views, I'm going to spend the last 5 minutes so you don't have to ask me how am I feeling and what am I going to do next. So the view as I walk round the corner is of the Shah. She has an even better one with paratroopers landing, but I thought that might get you too worried and you might want to go to the fire exits. We're changing guards at Buckingham Palace and Simon takes over, or at Prescottville. The view I'll have at my next job is actually the back garden at Buckingham Palace, so I'll be able to see the corgis being taken for a walk, so I'll be able to check there's no cruelty being done to animals, so that's good. I don't know why it's doing this, I'll just patiently see what happens next, it's always a surprise. So, am I sad to be leaving? Well, to be frank with you, I'm knackered, and you can't do this job for more than 3 years. And everybody says they can, don't let them. But I've got such a taste for lobbying. I did arts A-levels, so I could have easily gone in to be a civil servant like my father, and I had to catch up on science in 3 months, and that wasn't difficult. So Children and Young People's Mental Health Coalition is a membership group of 14 leading children's and young people's mental health charities whose aim is to campaign jointly to achieve policy changes to improve the mental health and well-being of children and young people across England. It was established by a partnership with the Mental Health Foundation, chaired by one of our previous presidents, Dinesh Bhugra, and funded, God love them, by Zurich Insurance. So I'm going to be lobbying, so those of you who've got anything to do with Parliament, watch out, and we're still going to chase you. Chairing the Inequalities Forum at the Academy, and from July 2014, I couldn't resist the invitation. The Head of Health Education, Wendy Reid, said, how do you fancy becoming a mushroom? Oh yes, really in the dark and eating, that looks attractive. But it is actually really exciting to be looking at how I can help to coordinate education and training workforce for the whole of health, not just mental health. So how I can try and help make every medical student more psychologically minded, every surgeon more psychologically minded, how we can be better at physical health care, and how we can deal with these slight tensions we have in teams, and where a priority has to be to improve the training given to this unskilled workforce across health that delivers 80% of the care. Nearly there. I was asked, should I give any advice? So here's a few handy hints. This is the beloved and iconic Glasgow School of Art. Thank God for the brave firemen of Glasgow who managed to rescue most of the building. So life is predictably unpredictable. Adapt. So if only fish are permitted to ride bicycles in the garden, or that's the terms and condition of going to see the minister, find a fish and stick it on a bike and follow them. Dead ends. I think as colleges and professional bodies we spend too much of our time stuck in dead ends. This is the knackered leader, and geese know how to do it. They swap and rotate, so there's Simon with council helping and supporting him. Listen to the trainees, because they are the future. Skate to where the puck will be, not where it has been, and again, professional bodies tend to get stuck in the past and fight battles that have long been lost or won and don't need to be revisited. And never stand between the dog and the lamppost. I was wearing a rain lamp this morning, so it was okay. So, users, patients, carers and mental health professionals deserve better. Ai Weiwei spent 1 week, he's my hero, haven't got time to explain why. Doctors come into medicine to make people's lives better. Gradually, the Cartesian view of the separate components of body and mind is being replaced with that of whole person care, whose mental and physical health are codependent. I've been tackled for not saying enough about women and leaders, so I hope Hillary Clinton's good enough for you. Looking at the world today as the lens of the media daily penetrates our living rooms with the reality of poverty, rising mental health problems, social upheaval, natural and man-made disasters, and we need to think about the psychiatrists across the world who are trying to cope with dreadful agendas at the moment. I can't help but reflect that mental health has a part to play in sustainability and disease prevention. And I think the pursuit of sustainability over the pursuit of GDP might leave us all in a better place. Hillary Clinton has said that nations invest in women's employment, health, including mental health and education, are just more likely to have better outcomes. Their children will be healthier and better educated, and there might even be fewer wars. So, on being me, thank you for all your support, and how's it been for me? This is an artist, Louise Bourgeois, born in 1911, died in 2010. It sits on my daughter's wall. It's got a swear word in it, which isn't good for the grandchildren, but what the hell. Louise Bourgeois was a woman who had a very difficult, troubled upbringing. And on saying how's it been for me, she said, I've been to hell and back, in parenthesis, every day, close brackets, but let me tell you, it was wonderful. Thank you for listening.